Thank you so much for joining this morning. This training is hosted by the Ohio chapter of the American Academy of Pediatrics under the Parenting at Mealtime and Playtime program, which is graciously funded by the Ohio Department of Health. In its 20th year of funding, Parenting at Mealtime and Playtime has provided evidence-based education to physicians, nurses, home visitors, community health workers, and beyond. Tackling a myriad of topics this year, PMP will discuss breastfeeding, creative ways to bolster nutrition, and how to navigate difficult weight-related conversations. Dr. Chris Bowling, faculty of this training, has no relevant financial relationships with ineligible companies to disclose. He will not be discussing off-label use of medication. Please note the views and opinions expressed in this training are those of the authors and do not necessarily represent official policy or position of the Ohio Department of Health. PMP handouts can be found on the Ohio AAP website linked through this QR code. The handouts are designed for caregiver and child use and provide information on various topics. The PMP toolkit has been designed with physicians in mind and is linked here. The toolkit has resources on how to increase your practice's presence on social media and common EMR phrases when working with a pediatric population. The PMP website has recorded trainings on supportive clinical spaces and engagement with patients and living in larger bodies and motivational interviewing. The Ohio AAP's Instagram, linked in this slide, shares short educational videos for a broad audience. The Ohio AAP is excited to continue this work of PMP and looks forward to diversifying its audience and topics. If you have any ideas for the toolkit or mobile app throughout today's session, please share your ideas in the chat or reach out to Sahavi, the PMP program manager. We always appreciate feedback from our learners. With that, today's training is hosted by Dr. Christopher Bowling. Dr. Bowling is a retired pediatrician in Cincinnati, Ohio. He was a founding partner of Pediatric Associates PSC of Crestview Hills, Kentucky, where he worked for over 30 years. He received his medical degree from the University of Cincinnati College of Medicine and has been in practice for 30 years. He is a medical director for the Ohio AAP Preventative Health Program and a longtime expert and advisor for the Ohio AAP's Parenting at Mealtime and Playtime program. With that, I will pass it off to Dr. Bowling.
Thanks, Suhavi. It's great to be here. And that was a very thorough introduction. I appreciate it. And what I'd like to kind of mention, everybody, is those resources that Suhavi mentioned that are on the PMP website are fantastic. I'm going to give you some other ones that this talk, which has been developed by AAP with some help from CDC. There were some resources that are on their website as well, but I will tell you the AAP websites, Ohio AAP websites, are better. To remind you what our learning objectives are today, we're going to go over the importance of early feeding. We're going to go over key protective and risk factors and recognize the role that you can play in supporting the adoption of healthy, active living strategies. So just to refresh for you, so what's the issue around nutrition? Well, approximately 17% of children and adolescents between the ages of 2 and 19 have obesity. There's a higher prevalence of obesity in minority, ethnic, and racial groups and in children in poverty. And it really seems to relate to that poverty factor. As we know, race is a social construct, but this really, it really is related to social determinants of health and poverty and economic issues. So that's a switch. Young children are also impacted. We think that 1 out of 3 children have obesity or excess weight before their 5th birthday. And it's not just that they have higher weight status, they actually have some undernutrition, and we'll talk about that as well. And I know that's something that is not a surprise to many of you. What we do know is that children who are diagnosed as having overweight or obesity as preschoolers are 5 times more likely as normal weight children at that age to have overweight or obesity as adults. So you'll hear all sorts of numbers, but the number we think is about 5 times more likely. The first 1,000 days of life we know to be very important. Nutrition, environment, and relationships that are formed in these first 3 years of life really matter. There have been a lot of initiatives around these first 1,000 days. And when it comes to nutrition and activity, it really makes a big difference. Early childhood, we know, is a critical period because children are really acquiring their eating, activity, and sleep patterns. And age 0 to 5 is a really unique window to be able to shape healthy habits. There's a lot of evidence that there's evidence base around a number of factors that really affect the early onset of good nutrition and obesity prevention. And I'm going to use the terms good nutrition and obesity prevention sort of in the same way. You have to understand, I'm coming at this, and this is put out by the Institute for Healthy Childhood Weight at AAP. So there's a bit more of a focus on pediatric obesity than I think a lot of us you may really acknowledge at first, but they're almost synonymous. Good nutrition and obesity, for our purposes here today, are pretty similar. There's a lot of divergence in other topics in other areas, and when we talk about obesity, but for today's, we're going to sort of use them a little bit interchangeably. But it's things like rate of weight gain, infant feeding practices, use of bottle feeding, sleep, limitation of TV time, diet quantity and quality. All these things are factors that we know are modifiable factors in the promotion of good nutrition and the prevention of obesity. We also know that good nutrition and obesity occur in a wider setting. If you remember your socio-ecological model, where we have these nesting rings here, we talk about things that affect broader determinants, lifestyle, genetics, all the way down to like very, very personal things like your like you say, your genetic makeup. But all these things, what's supporting you around you, what's supporting your family, all these things have a big impact. We can also look at promotion of good nutrition from a developmental perspective, and that's taking it all the way back into pregnancy period. So we know that there are factors that occur during pregnancy and young childhood that really have an impact, and maybe just as much as any other part. So we can look at this from a developmental perspective. So if we take all of these things that I just mentioned, all these different things that we know there's evidence around, and look at it through a developmental lens, we can really start drilling down. So what are kind of the things that make a difference in pregnancy? Well, it's things like appropriate maternal weight gain. It's limitation of smoking. It's gestational diabetes control. It's regular exercise during pregnancy. It's a healthy diet during pregnancy. And it's good prenatal care. So we know these things have an impact also on nutrition and outcomes with regard to nutrition. The perinatal period is also very important. It depends on what your baby's birth weight is, if they've made it to full term. It depends on breastfeeding initiation and sustenance. It depends on mom's returning to a healthy weight after pregnancy. It is affected by maternal depression. It's really affected by a lot of things. Early infancy has its particular things that factor in. Again, how growth is going, breastfeeding factors, active, healthy play, understanding hunger and satiety, and we'll get to that one. That's a really important one for today's talk. It's about the maintenance of breastfeeding. It's about responsive bottle feeding. Again, something we're going to spend some time on today. The introduction of appropriate complementary foods. And it's about responsive and authoritative parenting techniques. These last four are going to be the ones we're really good. Last 4 or 5 are the ones we're really going to drill down into a little bit more today. Infancy is affected by things like self-feeding. It's affected by variety and textures of flavors, by routines, by time spent in devices, by beverages, fruit and vegetable consumption. It's affected by responsive feeding practices again. Limitation of screen time, active play, and sleep, as well as role modeling, can have a big impact at this age. As we move on into toddler and child and preschool ages, it's things like ongoing fruit and vegetable consumption, it's fiber intake, beverages, daily active play, again, limitation of screen time, appropriate sleep, role modeling and responsive parenting, exposure to advertising, and things like snack and meal routines. So there's a variety of things. I always say that those of us who go into nutrition and go into pediatric obesity are sort of chaos lovers, or I should say, we like to bring order out of chaos. There's so many factors that go into a development of a good nutrition plan that it's almost impossible to keep track of all of them. You have to be somebody who really sort of gets into managing a very complex environment. Pediatricians have a bit of a special advantage in that we have 31 well child visits during the first 21 years of life. And of those, 20 of them are in the first 5 years of life. And this is not counting any of those special visits for behavior, special visits for illnesses, other opportunities to talk with families. So we have a really good shot at them, no pun intended, for seeing these kids multiple times early on. When we ask parents where do they expect to find things about childhood obesity and nutrition, it really is places where all of us sort of function in healthcare settings. And I would expand the use of the word doctor's office here to healthcare settings. It's also in media, it's in school, it's in our community centers, after school programs, but places where those of us in this room today operate. It also shows up in other places like workplaces, places of worship, but really the big places are those healthcare facilities, community centers, and places where we as healthcare providers interact with them. And by healthcare providers, I mean all of us, community healthcare workers, visiting nurses, all of us. The role of pediatric providers in general is that, number one, we play a key role. We're a trusted source of information, and we get to see them a lot, just as I was saying. So we have a lot of opportunities. Other providers, those of you who are home visiting professionals of all stripes, you have a unique look at the home setting. I think I've never learned more than I do when I do a home visit with a family. You just get such insight and it sticks with you. You remember, those pictures are worth more than 1,000 words. You really remember, like, okay, this is what I remember seeing in those settings. These are issues that might be of more help with this family if I drill down on this. Okay, this is a family that has very limited ability to get outside because of where they live. You get a better understanding. Those of us who do home visits really have an opportunity to provide some practical tools. We can actually look and see where they are, what their resources are, and what might be possible for these families. It's a chance to demonstrate what really works. It's a chance to do some of that very important role modeling. Community health workers, what do we have the ability to do? Tailoring for special populations, cultivating collaboration, developing effective and unique messaging. And we really have the ability to do a variety of things. And I know I'm missing it for our community healthcare workers for some of the things that you're able to do. Childcare providers, chance to model positive behaviors. I had one of the most touching moments, I'll have to say. I do a lot of work with childcare providers in one of my roles in Northern Kentucky and working with the Northern Kentucky Health District. I had a wonderful, wonderful childcare provider say to me, she was someone who had severe obesity. And what she said during the process was, Dr. Bowling, who am I to tell people how to drink healthy beverages? I mean, all they have to do is look at me and know that I struggle myself. And I said to her, I said, there's nothing, when we talked about it further, I said to her too, it's like, there's nothing more powerful than someone who struggles with it saying like, hey, I share your struggle. Like none of us are perfect. None of us are going to be, like always at exactly the right weight or look exactly the right or have free of all weight related illnesses or nutrition related problems or diabetes issues. It's not about what we look like in the first place. It's about health factors. And sometimes it's better to hear from people who share the struggle with you. So I think it's important that modeling of positive behaviors, give yourself credit. We're all working. We all are trying. We have a great opportunity. Parents really see what happens. I can't tell you how many times I've been reminded of meetings that I was the one who brought the pizza lunch to. They said, you were talking about obesity. What are you doing? So I'd you really have the ability to harm or help yourself by doing good role modeling. We really get the chance, and childcare providers get special ability to provide skills to families. We also really have the ability to motivate kids as change agents. We always talk about this, kids had a profound influence on reduction in smoking rates in our adults. They have the great ability to change their parents' behavior. So what do we all need to do? We need to be consistent. We need to be singing from the same hymnal. Many of these skills are easily practiced. It's not, it's one of those things like it may be simple, but it's not easy. So we have to be able to make sure that we're being consistent and that we're showing these behaviors together. And maybe we'll get a little bit of a halo effect. I think we notice that when parents and kids see things in multiple locations, when their childcare facility and their school are saying the same thing that their physician is saying or their medical provider is saying, there really is a bit of a synergy going on. So our focus for the first year is really around some very specific things. We want to improve feeding practices. We want to support breastfeeding. We want to encourage movement and activity, and we want to support development of good routines. This can look like things like eating more fruits and vegetables, drinking and eating less sugar, moving more, limiting screen time, establishing good routines, when possible, eating together as a family, fostering good self-feeding and responsive feeding. So what are your pediatrician colleagues good at talking about, and what are we really bad at talking about? Let's take a look. So as pediatricians, so these are the issues on the left-hand side over here are the things that we know are evidence-based. And these are not rank ordered. This is how often pediatricians are addressing it. We pediatricians are good about talking about limitation of consumption of juice. We're good about beverages and juice in general. We're good about talking about promoting fruits and vegetables. We're pretty good about sleep and physical activity and screen time. Where we start falling off are these things down lower, and we'll talk about those in just a second. But before we go down to this bottom area where we're pretty lousy, let's talk about this top part where we're doing some things and talk about why these are important to continue to stress. Well, we know if we look at kids, that when we look at young kids, 16% of kids are introduced to solid foods before 4 months of age. 38% between 4 and 6 months. And when we really get to that point where we really technically say 6 months, only 33% wait that long. What we know is from kids, when they do get started eating, that their numbers look pretty good. At eating fruit and vegetables on a given day, 60% or more, up to 70%. Only 20% of 6 to 11-month-olds are eating grains. And while 14% are, I think you could say 86% are not eating sweets. Would like that to be 0, but pretty good. Well, what happens though? Well, 19 to 23 months of age, well, we're still eating fruit. Vegetables are beginning to decline. So if you noticed, we went from 57 down to 45, and that's going to continue to drop as we move along here. 87% already are moving up in grains. 87% are eating grains. So that went from like less than 1 in 5 to almost 9 in 10. And well over half, almost 2/3, are eating sweets on any given day. Big changes that happen from that first, that from 6 to 11 months, then suddenly from that last half of the first year, it's really changed. And what we know is it really plays out in quality index scores. So we really need to be talking about this, because if we look at the quality of scores, it declines pretty steadily. These are scores, the dietary quality index scores, that drop from being in the high 20s down to about 20. Now, I can't give you a whole lot of details on what is an acceptable level here, but just suffice it to say that diet quality drops dramatically over those toddler years. So we've got a problem, and it's worth looking at, and it's worth working on these things. Some other relevant patterns that are going on. We really know that the toddler's diet is the transition to complementary foods is really important. That the toddler's diet really affects the eating patterns of adults. We know that there's too much screen time, not enough activity, and we know that sleep patterns can start falling apart. Timing is really important. We need to really be thinking about what's going on with our families. We do not, none of us in this room have time to address everything all the time. And even if we did have time, you think parents could listen to everything? They don't. We need to pick and choose, and we need to figure out what is most important. So we need to really think about those things when we're talking about this decline in dietary quality. We need to be thinking about when it's occurring and really concentrating on that, in my opinion, at 2 times: when we make that move to complementary feeding, and in those toddler years when dietary quality starts really dropping off. So what do pediatricians kind of stink at? We're not very good about reminding families about eating together as a family. And again, that means something different to every family. We're not very good about not cleaning plates. It's the red circle is sort of blocking here, but it's not forcing the child to finish food or bottles. So this is, basically this is talking about we're forgetting to say, don't be a member of the Clean Plate Club. Maybe some of us are still saying that because it's such a powerful cultural thing, but we're really forgetting to say, like, quit eating when you're full. Don't just keep eating. You want to be creating. We rarely talk about creating a pleasant environment for feeding and making it enjoyable. We rarely talk about not feeding in front of the television. We really don't talk about hunger cues. We don't talk about feeding practices, and there's data behind all these things. And we really don't talk about not providing food as a reward. So these are all evidence-based things that we're kind of forgetting about. And not to cast stones, not to make everybody feel guilty. That's not what we're here about, but we've got some opportunities here. So what are some things in those early years? It's really about maybe trying to work on these things about eating together as a family. That knocks off a lot of those topics. That knocks off a lot of that eating in front of the television set as well. Fostering self-feeding and responsive feeding really gets to this root of like not being a member of the Clean Plate Club and really listening to your child's food cues. This is an important piece that will help you sort of get that bottom half of the curve, half of that graph. If we can tailor it around development, around anticipatory guidance, around risk, and around parent concerns, we can really make some good progress. So let's talk about what this is going to look like, and then we're going to go over some different ideas for you on how you can incorporate this responsive and feeding principles into your practice. So let's take case study 1 for starters. And I'm going to ask you to unmute and chime in, or feel free to use your, I'm not able to really see the chat box right now because of the way we have our Zoom structured, but feel free to use the chat box. And Sahavi, if you can kind of watch that for me and chime in with any questions or comments that show up in the chat box. But also, please feel free to unmute yourself and chime in. We don't have a huge group. I'd love to hear what people have to say. So Callista is a lively 18-month-old. We're going to back it up here. Let me get this back here. Callista is a lively 18-month-old girl in for her well child check with her mother, Lexis. Lexis has severe obesity and is scheduled to have bariatric surgery in 4 weeks. You've been alarmed that Callista is already beginning to follow her mother's pattern. She's well over the 99th percentile for age and gender on BMI and weight, and at the 98th percentile for length. During the visit, Callista starts to cry and disrupt your discussion with Lexus about the importance of baby-proofing the house when the toddler is present. Lexus is very engaged with the discussion with you, and because she wants to hear what she's hearing, what you have to say, reaches into her bag to give Callista a bag of fruit snacks to quiet her down. So what are your thoughts? And is there anything to do here? Obviously, I'm leading the discussion in one way, but is that an appropriate way to lead it? What are people thinking here?
I think a discussion needs to be had with Carlista about what do I say, rewarding her with food, or trying to stop her from doing something with food. Like they already said, she's in the 99th percentile for BMI, so the last thing she needs to be giving her is a bag of fruit or vegetable. I mean, anything at that point, any type of food. She needs to just stop giving it to her like that.
Yeah, and that's exactly where I was sort of going with this. And thanks, Denitria. That was terrific. That was a great response. And that's actually, kind of where you have to be really careful because you don't want to be shaming. You don't want to be, you don't want to be really, like everybody parents in different ways. And we all know how it is with an 18-month-old. Sometimes you just got to do what you got to do. But it's also might be a little bit of an opportunity to say, like, hey, yeah, that's okay. Don't worry. She's not bothering me. We can let her cry. We can let her. I can't tell you how many times you do that in an office where parents are like, oh, we got to have them quieted down. I'm like, no, we don't. We all of us work with kids. We're comfortable. And even sometimes not even just saying like, hey, you don't have to give her any of the fruit snacks. You can just say, hey, don't worry about that. We'll just let her cry. Let her, we're okay. We can keep talking. We can totally sort of ignore that behavior and move on. But it might be an opportunity. And what responsive parenting would say is this might be a golden opportunity to just kind of demonstrate it. Again, being very careful about shaming. You don't want to do that. But it might be an opportunity to just say, hey, what we don't like you're saying, Denitria, we don't need to use food here. So what responsive parenting will tell us? Responsive feeding, let's talk about it a little bit. It's a form of responsive parenting. And what we know that when you were responsive, we're using the child's development. We're actually looking at what they need. The caregiver's recognition of the cues can have really big impact on the kids. The kids know that the parents, this is a critical point in development where kids kind of realize, I can trust this caregiver to know what I need. So not only is it important from a standpoint of using food appropriately, I think it speaks to something deeper. It speaks to that this person knows me and this person knows what I need. And that translates all the way across parenting, feeding, everything. This is what we count on those caregivers for. We're young, we're impressionable. We just know that we're upset. We do a lot of parenting stuff where we talk about, what's called the Haltz mnemonic. I don't know if you've heard about this. Our kids, rather than being like they're upset, we don't need to fix the upset, but are they hungry, angry, tired? What's going on? Is there something that is that something else that's occurring? So it's an opportunity to really read them. What we can do, if we do these kinds of responsive things, if we're able to say like, okay, what Callista needed is not food, maybe she needed to be distracted by something else, or she needed a quick hug, or she needed something to just say like, hey, I'm still paying attention to you, even though I'm talking with talking with my dietitian here right now. So you can, maybe it's not around food. And what we're trying to do is we're trying to create this environment where kids are actually getting what they're actually asking for. Responsive feeding, like I say, is a component of responsive parenting, and it's all because infants and toddlers really rely on their caregivers to meet their basic needs, feeding and otherwise. So what is it with responsive feeding? So what we really want to teach families is, what are those signals for hunger, satiety? How do we respond to them? And then sort of helping parents realize, okay, you're getting this feedback. This is the response to that. Okay, this really worked. Like, okay, I think this is about feeding. I did this. That worked. So we're trying to get this feedback loop going for parents. And this is not necessarily intuitive. So it may take us as providers to say to families, like, let's try this. So, okay, so Callista was not really hungry. Let's try this. Hey, did that work? Did that not work? So it's not about getting it right every time, but it's like saying, hey, we're all learning here. What is it that makes Callista tick? Why do we do this? Well, because we caregivers and infants really interact through feeding. I mean, this is a basic way, and again, it bleeds over into other areas. Like, feeding is one aspect of parenting, but responsive feeding is associated with healthy feeding patterns later. It helps support self-regulation skills, and it really does lead, the evidence shows that it leads to healthier eating habits later. Hunger and satiety, it really helps caregivers tune into their infant and view it as a two-way interaction where they'll get some feedback. And we want to encourage caregivers to be looking for that. We want to help them sort of like, be watchful for this, see if this works for you. And if it doesn't work for you, let's adjust it. And again, I keep saying the same thing here. It's the first step in really helping that relationship that we think actually goes over into other parts of parenting. Just like it was with Callista, the practical tip here is pointing out hunger cues, not only like with Callista, where it was not a hunger cue. You may see opportunities where they're sort of like thinking like, I've got to be paying attention to you as the visiting nurse right now. But as the visiting nurse, if you see that the baby is like moving their hands to their mouth or is hungry, seize the day. Who cares about your other stuff? If you can get through to this family like, hey, no, this is a hunger cue. Use this hunger cue. And maybe when they see that when you see the kids stop eating, to know that that's a satiety cue, even better. Things like bringing their hands to their mouth. If you see a rooting reflex, if you see fast breathing, clenching fingers, flexing arms and legs. And again, if you see the satiety cues, pushing away, stopping sucking, extending arms or relaxing, falling asleep. One of the things that we talk about with breastfeeding, there's a lot of reasons we think that breastfeeding is helpful and promoting good feeding habits. One of the things is if you're breastfeeding, you have no idea how many ounces that child has taken. All you can work on are satiety cues. They may have taken 2 ounces, they may have taken 6 ounces. You don't know. And so that's a good thing. We want the same thing to go. We want to break families we want to be able to break families from the slavery of being able to, like, I've got to always be 4 ounces every single time. We really want them to be, not stuck with the bottle volume amount. We really want them to be looking at their ability to respond. Hunger and satiety at 6 to 12 months can look a little different and can be opening your mouth, reaching for the spoon, tracking with foods, pointing to food, expressing a desire. And again, watching, it looks different. 6 to 12-month-olds, we all know the look where they keep their mouth pursed closed. So, some of the ways you can approach this with families, some nice open questions. I love teaching motivational interviewing, so I love open questions. Things like, how do you know your child is hungry? What is it like feeding your child when they are hungry or very tired? How do you know your child is full? So these are great questions that you can use to kind of say, like, let's talk about what this responsive feeding might look like. We have some good things that you can post in your office, both from PMP and from AAP, and we'll show you those. So let's talk about case study 2. So Gina and Kevin are parents of 6-month-old David. Gina has a strong family history of type 2 diabetes, and Kevin a strong family history of heart disease. Both families have a strong history of obesity. Kevin is an extremely picky eater and has been his whole life. Everyone says he's just like his mom. Gina's older sister struggled with an eating disorder, and she has told them both that she was weight shamed, that the kids are going to be whatever weight they are and should not worry about weight status now because it'll just cause an eating disorder if they say too much. Gina and Kevin say they do not know what to do and ask the question, what should we do about feeding? Lots to unpack here. Lots of family history, lots of stuff weighing on these families. And this is the way our families come to us. You know, they come in with all sorts of family history and all sorts of biases, one way and the other. And they've heard a lot. So what are your thoughts on this? And what are your goals for David? How do you start this conversation? Love to hear what people have to say. So please unmute yourself and volunteer. We'd love it.
This is Sue Vargo. This is such a great conversation. I appreciate it, Chris. But I think I would start off just saying we want him to be healthy, you know, not talk so much about weight.
Yeah.
And how do we keep him healthy? You know, they have a family history of diabetes. We don't want that, heart disease. So
Yeah,
that's how I would
absolutely,
approach
Sue.
it.
Absolutely, Sue. And even the eating disorder, we don't want that either. I mean, we don't want any
No.
of these things.
Mm-mm.
So yeah, so I think that is an absolutely great thing to say. Does anybody else have any other thoughts too? But keeping it with the health discussion. What about anybody have any thoughts about like, wow, this even at this age, I'm worried about eating disorders. You know, I think that the data would say we do want to talk about this in a constructive way. We do want to stay focused on health. We don't want to stay focused on weight status, and we really want to focus on you know, promotion of health. But if we don't say anything, we think a lot of times that, you know, that's probably the worst thing to do because, you know, parents are thinking about it. So leaving the stone unturned sometimes is not helpful either. So what are some things we can do to get this started? Well, what we learned from parents is we asked them these are a bunch of focus groups. What do we do? What do we know that parents say? Well, they want what's best for their children, but they're very confused about the messages and strategies for a healthy, active living. They're confronted daily with an environment that really makes it hard. Caregivers do think that obesity is a serious problem. However, they don't think it's something that's relevant in infancy or young childhood. And they're really receiving mixed messages. They don't like the worst use of the word obesity. So to your point, Sue, you talk about health. They want guidance on too much guidance, I should say, on future outcomes is also not helpful. So in this family with type 2 diabetes, that's an important part of tailoring, but just know that even a family with a history, they may not be focused overly on future outcomes. So we as caregivers often are overly focused on that. And that may be an area of disconnect for us. So that, you know, like we know they're concerned about it, but it's not an excessive amount of concern on there. And they have limited knowledge of what the recommendations really are. And there's a real disconnect between the guidance that they often get and their personal experience. So what do we do? So we want to use the terms healthy, like Sue, your perfect response in there. We want to use growing healthy and healthy weight and health conscious instead of overweight and obesity. That doesn't resonate. So what's our goal? How are we going to help you stay at a healthy weight for life? And it's, you know, it's really good to be positive. It's like, I'm really glad that you're asking us this question. You know, I'm really glad that you're looking for advice from us because it really is. These first few years really are important. So their comment, like, help us make sense of all this. You want to reward them for that. That's a really good thing that they're doing that. What made it easier for them to hear? So they want to be respected for their expertise, for their understanding of their own child. Sounds intuitive. I can tell you a lot of times we forget to do it, but just those easy, common things like this is really hard. But being able to really respect what they're doing, explaining the why, but not overly, like, why do we care about this? It's not because we care. It's not because we want you to be able to fit into size, whatever. It's because we're concerned about health. They want strategies that are actionable and tailored, meaning listen to me, listen to what I'm telling you, not just what the recommendations are. You can go on forever and ever about not starting solids until 6 months, but if they've already started at 4 months and you don't know about that and you just go on about that, you're gonna make them realize that, like, okay, this person didn't even realize that I told them I've already started. So, you got to take time to understand where they are, respect what they're saying, and it's got to be tailored to them. Again, just that acknowledgement of, like, no one knows better than you do. Tell me about it. Acknowledging real life experiences, like the role the grandparents play in this, the role culture plays in it, the role being having a job plays in this. All of these things are going to profoundly impact what they actually do at home. So to not acknowledge them really is kind of tone deaf. These things, their work situation, their family situation, their cultural background, all makes a big, big difference. And that's great. So you want to include the why. And again, but what I'm going to tell you with the why is simple and clear. For example, like, we talk about, like, soda juice and sugar sweetened drinks. So you want to be really basic. We don't want to get into, like, okay, this is going to change your insulin metabolism and diet drinks are this and that. Da, 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 da. Like, no. We just don't want unnecessary calories because they need nutrition. They don't necessarily need extra calories. You can really get them used to the taste of sweet foods, and they're really bad for their teeth. Simple, direct, very short. And parents really say, this is what we want. Now, not every parent. There are going to be some parents, when you have that family the mom who's a diabetic nurse educator in there, drill deeper. But again, most families want you to keep it short and sweet and germane to their life. So, you want to combine. While you don't want to focus overly on long-term, you do want to mention them, but don't forget to give some immediate carrots in there as well. Breastfeeding will definitely benefit long afterwards, but it also will help you miss work less. Will generally make you miss work less often because the babies get sick less often. Be realistic and actionable. For example, this example is about, like, TV. If it's gotten out of control at home, you're not going to make a lot of groundwork when you say, okay, no more than 90 minutes a day. It's got to be educational. Like give them something that they can actually do something with. Maybe we just skip the ads, or maybe we turn off the TV during specific times as a starter. Maybe we just get it out of the TV routine by talking about blue light. So go for those little victories. Like, we kind of gotten away as the AAP from the 2-hour limit. It's not because we don't want we want kids to be watching more than 2 hours. It's that we've kind of gotten real about it. It's like, some families, if we can make small victories in certain areas, we go for it. Listen to your family, personalize and customize information, tailored prevention guidelines. Case study 3, Lanaya. Lanaya is the mother of 2-year-old Luis. She and her husband Carlos moved to Ohio about a year ago after emigrating from Venezuela. Lanaya works 2 jobs and recently got a new apartment. Luis is also working 2 jobs, and they're beginning to turn things around financially. Lanaya is getting pressure from her mother-in-law to quit breastfeeding and start Luis on solids. Her mother-in-law is worried that breastfeeding is too hard on all of them, that they're working too much. So what are your goals for this situation? How do you start this with Lanaya about how to feed Luis? Love to hear what you have to say.
I would explore, with Lanaya, why she thinks her mother-in-law might be pressuring her to start solids. Is it because yeah.
That's awesome, Tara. So yeah, a simple question. Like, I love what you did with that, Tara. Instead of like going into like, you got to keep breastfeeding, it's really important. Here's why breastfeeding is important. It's like, so tell me more about what your mother-in-law is saying. Like what is the root of her issue on this? It could be anything. This could be all sorts of things. It could be like she's worried because maybe Lanaya is depressed and she's got some postpartum and she's feeling like breastfeeding is too much for her. Or it could be that she's feeling like, like she's heard things about bottle feeding, that it's superior nutrition, or she's heard things that you may be able to correct. But you did a fantastic thing there by just stepping back and saying, okay, let's delve. I need more information here. What's really going on? And then also, you could also go into some conversation like, tell me more about how breastfeeding is going for you. Like what does this look like for you? And maybe you'll get an insight into what her mother-in-law is concerned about. So your goals are great, and your goals are important. Like I'm sitting here thinking like, okay, my goals with Lanaya is that she keep breastfeeding him. It's like, okay, this is, they're just beginning to make ends meet. They don't need more expenses. They need, I'm not real happy about this. I know that they live in an apartment that I'm a little worried about lead in that part of town. There's all these things that I love to see them continue to be on breast milk. But maybe the conversation needs to stop a little bit short on my goals. And maybe it needs to be a little bit more around what's really happening here. So what responsive feeding is doing here, what responsive parenting is doing here is sort of looking a little bit more at the situation and looking a little bit more at, how can we support this particular family? How can we tailor our messaging? How can we help them understand how they can look at feeding in a little different way rather than just rigid? Any other thoughts? If you're getting the sense that this is a little bit like marrying a couple of topics, that is what it is. It's like, we're talking about like stepping back from family situations, listening to families, finding out what their challenges are. We've got a lot of areas that we can target. And one of the areas that might be a really great place to target is this responsive feeding piece, because it can help you really address a lot of issues. So for example, like with Luis and Lanaya, we can kind of go into this stuff like, if we talk about Luis and his feeding, like we can talk a little bit about like how breastfeeding really is great with responsive feeding and really reinforce for her the good things that she's doing in responding to his satiety cues and his hunger cues. So that's sort of where we're driving at here. So we have some additional resources for you. There's some stuff at the on early obesity prevention and good nutrition at promotion. This is at the Institute for Healthy Childhood Weight at aap.org. There's some CME modules, and Sahavi will have these linked as well for you in this talk. But they're available in English and Spanish, both on the PMP and the AAP websites, which is very important to have that. But we have a lot of different resources for you, different infographics on responsive feeding. We have some ideas on finger foods. And again, we have some great stuff at PMP on this. PMP is just the best on this kind of stuff. but if you go at the AAP website, it's aap.org, and you go to early feeding HAF for healthy active living for families. That's what the HAF stands for. If you just Google HAF AAP, it'll also eventually get you there too. So with that, do we have any questions?
Chris, a quick question in terms of the transition time. I know currently our WIC packages still offer pureed foods as opposed to baby-led weaning. I just wondered how we, with our families that are dependent on WIC, I tend to just tell the families to avoid buying the pureed stuff and just feed what they're, feeding at the table and let the child self-feed. I just wondered how you, what your thoughts were on that.
I'm very sorry. I have because I don't have control over my mute button. My Bichon is going crazy in the background, so I apologize for that. That is coming from me. So your question was about. I'm sorry, I got a little distracted there. I'm so sorry. Your question was about self-feeding at the table. Is that right?
Yeah, well, particularly for our WIC families, because right now the WIC packages still haven't caught up with the new guidelines. They still
Yes.
Offer pureed foods at 6 months, and many pediatricians, unfortunately, I hear all the time, are still even recommending starting solids at 4 months and starting to spoon feed purees rather than allowing the child to do responsive feeding with off table foods. And so, for our WIC families in particular, I usually just tell them not to worry about buying the pureed stuff, but I know that's a challenge because financially, they depend on WIC for the baby food, but I will just tell them to feed whatever the family's feeding at the table, and wondered what your thoughts were about that.
Yeah, and I think I'm in the camp on this one too, where I think most kids really are at 6 months, but I think what you'll find a lot of pediatricians and a lot of pediatricians saying to families, because there's a lot of families that do start earlier, that it's really about developmental stage than it is chronologic age. This is a little tricky, like because you'll find some. I mean, I think there are some 6-month-olds who aren't ready. There's some kids, 6-month-olds, that still have an extrusion reflex where they're still pushing stuff out with their tongue. They are clearly not ready for solid foods, even though they're over 6 months. And then we have those 4-month-olds and 5-month-olds, 5.5-month-old, who really is like really interested in things and able to handle them quite well. So I think you're going to find some flex on that in the pediatric community. And I don't think that's necessarily bad. It's a little confusing because, like you say, we want to have very specific guidelines. I think what you're doing is the right thing. I think you say, like, in general, most kids are not ready for solids until 6 months. And you're going to see some variability in this amongst different providers, amongst different kids, because they're all different. Some kids aren't ready by 6 months. Some kids are ready a little earlier. But in general, it's 6 months for starting complementary foods. And that's what we encourage. And like I say, there may be some reasons that they start early, but we want those reasons really to be around food readiness and not, unfortunately, we don't want it to be around, like cost things. We want it to really be around their food readiness. And that's what I would stress on them. Like, if they are like, if they've started a little early and they're loving it and it's going great, then I feel like I'm not right to say, like, oh, you got to push back. There's not a real reason to push back. But if they're by the same token, if they're 6 months and they're not ready, it's good to not start. I hope that's an answer to the question. But I think I would be cautious about being really rigid about the 6 months, because you're right. You're going to be get some differing opinions from other providers out there. Oh, great question too. Wondering more about baby-led weaning versus spoon feeding for purposes of response. Oh, I gotcha. I honestly, I think there's some really, I think that's a great, I'm sorry, I kind of missed your question on that, Tara. I think baby-led weaning, is sort of it's kind of some old names for new names for old techniques that are kind of tried and true. I think, you know, like we got to really be careful about choking. There's no question about that. But the aspects of baby-led weaning that are around self-regulation, that are around readiness to feed, like I was mentioning about, you know, when kids are really ready and not starting until they're ready, I think those are really important. So from a baby-led weaning perspective, I think baby-led weaning is very helpful with regard to the responsive nature of it. Again, I'm a little nervous about the choking part. We got to be really serious about that. But I think that the self-regulation piece is really a good part. So with that, I'll turn this back over to Sahavi for the last part.
Dr. Williams had one more comment in the chat, Dr. Bowling.
Yes, and
Sir.
I can't see it, so you're going to have to read it to me.
Oh, no.
I'm sorry.
Sahabi, no, I just because I had sent the question privately, so I just posted so everybody could see it. He already responded. Thank you, Dr. Bowling, for a wonderful presentation.
Thank you.
Thank you so much, Dr. Bowling, for facilitating this great training today, and thank you all so much for coming. If you like today's training, the PMP program is offering another training, this is the PHP Preventative Health Program, also through the Ohio AAP. We are offering a training January 24th on Zoom, discussing screening for maternal depression at the well child visit. It's a family affair. This is hosted by Cincinnati family physician Dr. Lazaron, and the QR code to register is on the screen. And I'll be following up with these slides, as Liz mentioned. I'll be following up with the slides and all the relevant links and things like that. The PMP program, Parenting at Mealtime and Playtime, is also offering another training on January 31st, 2024 at 12. It's on Zoom. 1 hour of CME and MOC Part 2 are going to be offered. This training is hosted by Dr. Marnie Walston. It's discussing navigating difficult weight-related conversations. She's going to walk us through some of her experiences in pediatric obesity medicine and tell us how to be better providers for those who may be experiencing weight-related issues. To claim your CME credit, please check your email for the survey and complete the survey. Within 10 days, if you could check your email, you should have your certificate. We ask that everybody do the CME survey so we can collect outcome data, even if you're not going to claim the CME. And this is my contact information if anybody would like to reach out with ideas for the app, the toolkit, any of our trainings. I'd love to hear from you. And here's all of our social media if you'd like to follow us. We put out a lot of really great content here. And if there are no more questions or comments, that will conclude our training today. Thank you so much for coming and bringing good energy. I appreciate your time and hope to see you in the future.